Dustin, shall we start? Okay, friends. We have come to the most exciting session in any conference. How many of you think that Ophthalmic Premier League is the most popular? Can I have a show of hands? Absolutely. Give a big round of applause for that as well. If you give pure science, the assimilation is only 30%. If we combine science with fun, the assimilation is 80%. And that's the reason Ophthalmic Premier League, which me and Amar started way back in 2007, when IPL started, has become one of the most integral parts of any conference and most popular as well. Let me thank Dr. Bastian, Chairman, Scientific Committee, Ksos. Another big round of applause for Bastian for conceiving such a wonderful program and making me the OPL anchor. By the way, I am Dr. Mohan Rajan for all of you. I am going to do the anchoring for the OPL, which is going to be very, very interesting. We've got 4 fantastic teams, fantastic players as well. I request now Anjana and Sonia to come forward and tell the rules and regulations for this OPL and also call the judges as well.
Thank you, sir.
Anjana.
Good evening, everybody. All set with the t-shirts?
Come.
Yeah. So myself, Dr. Anjana, and this is my co-host, Dr. Sonia. Are you all ready for this extravagant evening? Yes. Say some loud noise. Yes.
Big noise, please. We want cheerleaders.
Yes. So good evening, all. So we are here to conduct or to witness the most awaited extravagant show. What is that? OPL, Ophthalmic Premier League, right? So there are certain rules. Since it's a show, I ask you to.
So coming to the rules of the game, each team will be allotted 17 minutes. Intro video followed by 4 minutes per team member for the presentation. So competitors, a word of caution. Once the clock runs out, your points will begin to fall. The clock shows mercy to none. So remember that.
Yes. Is that clear to all the team members? There is a very tight time schedule. And at the end of today's battle, we are going to find out 4 awards. Okay, so that is first for the best promotional video, 1 for the best scientific content, 3rd one is for the best entertainer, and 4th is obviously for the best team. So why are you all here? You all have a role in selecting your favorite team or your favorite presenter. So I'll be going to the details later. So you all have to listen and really get into this game.
And steering this battlefield today is none other than the title of ophthalmology himself, Professor Dr. Mohan Rajan, Chairman and Medical Director of Rajan Eye Care Hospital, AIOS Vice President, a distinguished specialist in both anterior and posterior segment surgeries, who has delivered over 2,000 presentations worldwide, performed more than 158 live surgeries, a man of excellence in every sphere, and a proud winner of 89 OPL titles.
Thank you.
Let's welcome our esteemed host. I want you to give him a big round of applause, please, for Dr. Mohan Rajan. Sir, we welcome you. We are honored to have you as our host.
Thank you.
And we shouldn't forget our judges, because they have agreed to us to witness this show along with us. They have the eyes of justice, the keepers of standard, and the final voice. We have esteemed guests of honor and these judges across the country. I would like to introduce our judges to the audience. Dr. Prashant Pavankule, sir.
Please come forward.
Big round of applause to sir. Dr. J.S.
Balla.
He's coming. Okay. Dr. Namrata Sharma she's known to everyone here. All these are very renowned faces in ophthalmology. Dr. Ankur Singh,
no,
Dr. Maya Hada.
Want them to come over on top here?
No, you can sit there.
Sit there only? Okay.
Dr. Maya Hada and Dr. Ebi. So over to you, sir.
Okay, the players, where are the captains? The four captains, can I have the four captains here, please? Chandrakant, Anish, Alex Baby. Who is the fourth captain? Samira, no? Please come. Hi. Now, can I have the lot, Sanjana? Okay, judges are here, right in front of you. You can pay them by GPay, Phone Pay, NEFT transfer, check, checks which don't bounce, anything. And some of them require votes also, a lot of votes. Yeah, so make sure that instead of votes are more important than cash. Only votes. So make sure that all the votes go to them. Okay, anyway, where are the lots? Votes? What do you say? Oh, you understand Malayalam, madam? Nannaitu unda, unanga inja, joliya paathu pongo. That's the only Malayalam I know. Hey, lots, man, lots. Bastin, lots. Lots. No lots, huh? Okay. Okay. Okay, you catch my finger. Both of them are catching the same finger. Come on. Okay, this is 1, this is 2, this is 3, this is 4. Okay. Okay, you decide among yourselves. You want to go first, Natasha? Yeah. What's the name of your team? Cochin Queens. Okay. It's all female team. All ladies team. Come on! Yeah, let them go. 3.
We are happy that Dr. Mohita Sharma is also with us as a judge. Welcome you, ma'am.
All the players, yeah. Sorry.
Brown cataract patient came with a request for an EDA of iron. Plan was to do a good vertical chop to break the back of this dense, leathery, hard nucleus. I began by making a nice central pit to get a good grasp of the nucleus. The vertical chops went on fine, but as you can see, the fibers are quite leathery and quite stubborn to break through. But you need a little bit of patience. And finally, they separated. Now I take up each piece and eat up the nucleus. In the end, what do I see? There is a nice plug staring at me. This plug needs to be addressed, since the plaque will interfere with the vision of the patient with an EDOF IOL. Gently, I use a micro-access forceps to try and find an edge to pick up the fibers from the posterior capsule. My heart was beating fast, but my micro-access forceps had to be very still because the posterior capsule, which is just 4 microns, was at stake below. At no cost I wanted to lose the PC. Hence, gently, very carefully, I nudged the fibers of the PC plaque. I flattened the PC again with viscoelastic and tried at the edge of the plaque again. Finally, a major chunk of the plaque yielded to the microvexus, giving quite a clear PC. A disenclaved iris claw lens patient was referred from outside for management. On table, gravity was my enemy since the iris claw was dangling vertically down into the vitreous cavity, hanging on to dear life. My attempt to fish out the iris claw was not working. It was time to refashion the scleral tunnel. I made a small entry into the anterior chamber and again began my attempt to try and nudge the edge of the iris claw up. The pupil came down quite a lot and I needed a better view, so I thought of putting the iris hooks. 2 hooks and I got a slightly better view. I changed my approach and went superiorly using an iris deposit. Still no luck. I took a deep breath and gently went in with the humble Sinskey's hook. Yes, Sinskey's hook is managing to bring the IOL up. Now the next step was to hold the optic. I had to enlarge the wounds in order to get a better grasp of the optic. Gently holding it in the center, I pushed the IOL behind. A firm tuck to ensure that it is enclavated. There, you can see the dimple forming. Now we know that it's re-enclavated. The IOL is finally back in its resting hammock position and the patient's vision is restored.
Our story begins in scenic Maldives, where blue skies and green waters hide a deadly disease. This 20-year-old smart nursing student has transfusion-dependent stable beta thalassemia and developed left eye pain and swelling one day. She was started on topical antibiotics and oral analgesics, but soon she developed rashes below the lower lid that was increasing nasally also. She was treated as herpes zoster ophthalmicus with antivirals. She was also given sphenopalatine and mandibular nerve block for her severe pain. Few days after that, she developed sudden loss of vision in the left eye. Then she was immediately airlifted to the emergency department of Rajagiri Hospital. Ophthalmology saw her along with critical care, head and neck surgeons and ENT. Her vision was right eye normal, left eye no perception of light. She had periorbital edema and a striking black scar below the lower lid. EOM was limited and left RAPD was present. Cornea and AC were clear. Fundus showed only mild vitritis with mild disc edema. Lab reports showed raised counts, deranged hematological values because of her underlying thalassemia. MRI brain showed left eye orbital cellulitis with inflammation of deep and facial spaces. What do you think is the diagnosis? Yes, rhino-orbital mucormycosis. She was started on antifungal and nasal septal drainage and medial wall decompression done and specimen sent for culture. Repeat MRI brain showed occlusion of the ophthalmic and maxillary artery, for which she was started on low molecular weight heparin. But to everyone's surprise, culture showed no growth and there was no evidence of mucor. Histopathology came as necrotizing granulomatous inflammation with vasculitis, and immunology workup was also negative. By this time, she became worsened and her cornea had diffuse infiltrates and AC was full of exudates. The right eye continued to be normal. Whole hospital was buzzing. ENT, critical care, radiology, neurosurgery, all the big shots were stunned. What are we dealing with? Enter our heroines, Dr. Anjana and Dr. Natasha from lowly ophthalmology. We connected the dots. Beta thalassemia, iron overload, mucor-like presentation but not mucor. Pythium insidiosum, a rare oomycete that causes orbital pythiosis. And then the real chase began. She was initiated on linezolid and azithromycin, conjunctival biopsy sent for KOH and fungal culture. Unfortunately, she took a turn for the worse, developing new onset weakness due to an MCA infarct. We went ahead with intravitreal tap and sent it to AIIMS Delhi for Pythium PCR. In the meantime, KOH mount showed pauciseptate hyphae and culture plate showed white fluffy growth suggestive of Pythium. And clinching the diagnosis was the report from AIIMS Delhi confirming Pythium insidiosum. She had a rare case of orbital pythiosis, a life-threatening rare manifestation that occurs particularly in hemoglobinopathies like beta thalassemia. Multidisciplinary discussion and expert opinions from across India were sought and decision for enucleation and debridement was taken and systemic treatment continued. And that, ladies and gentlemen, is PS, the Pythium story, where ophthalmology heroine saved the day and the kingdom with timely diagnosis of a rare disease.
History tells us that powerful people come from powerful places.
Relax, Bhavya, come. We are live with the results of a thrilling match, the screen time survey among our undergraduate students. 201 students participated. All of them are young adults in the period of their psychosocial and cognitive development. Their screen time averages were smashing the boundaries all day. 61% of students with 4 to 8 hours of screen time and 11% with more than 8 hours. Bhavya, we'll find out what your score is, alright? Wow, here comes the silent assassin, the late night scroll. 56% students confess they lost their wickets to the tricky spinner after 10 p.m. You know, late at night. Most of us do not know what this blue light will do to our eyes. It damages our photoreceptors, the RP cells, and also it suppresses the melatonin in your brain and sleep is clean bound. Oh, that was a massive wicket down. Furthermore, 87% of students agreed that their daily digital use of academics was only less than 3 hours. And for leisure, over half of them said they crossed the boundary lines often. Mobile screens dominated the field in 99%, swinging hard and taking control of their precious hours. Even worse, 47% were using multiple screens at the same time. Man of the match was the social media. A respectable chunk of students agreed that they use screens just before sleep, and many of them agreed that screens were a distraction from their studies. Some felt anxious without their device. Some said they felt bravely to limit their screen time. And now for the match turning point, a significant number of students reported eye strain, headache, reduced concentration, and sleep disturbances. You also suffer from these, am I right? The endless scrolling and gaming marathons began to affect their academic innings negatively. They also had difficulty managing time and they found themselves procrastinating. When asked these questions, we got mixed responses, divided almost equally between yes, no, and sometimes. But still, most said no. What about you, Bhavya? We need to take breaks. Do you know that? And do you know about the 20-20-20 rule? It is very effective. Blue filters. Yes, they are the game changers. 41.3% students use blue filters. It cuts off all the blue light from entering your eyes. You remember what I told you about the blue light? Yes? Well, that was educating. Bhagwata. Awareness was stepping up as the new all-rounder. Turning to the internet, she downloaded apps to monitor her screen time. But she kick-started a war game with her own mind. She also set boundaries, physical barriers, keeping all her digital gadgets away while studying. With the help of her friends, she set up screen-free zones in her department. Completely removing the screens is not the solution. Instead, we must see it as a tool and never a habit. Replace the habit, not just remove it.
History was wrong. Powerful people make places powerful.
Every test says he's fine, but he's not. That's because we haven't asked the right question.
Look, the symptoms are not correlating with the findings.
Ma'am, are we missing something?
Exactly.
Doctor, help me!
The number one question I get is, how did I get into this?
Introducing Uvioscope. Uvioscope is a mobile-based application designed to bridge this gap by helping doctors to make informed decisions, ensuring a precise and efficient diagnostic pathway. Now let's see how this works. Download Uvioscope from the mobile application Play Store. Enter the demographic details like this and start with symptoms in detail, whichever is relevant to us, to our patient. Enter the past history, uveitic positive history, systemic and drug history. You will get a summary of the case. After that, going into the examination, enter the vision, relevant anterior segment examination, which will include only positive uveitic signs, which is relevant to uveitis, and posterior segment examination findings, whichever is relevant, and at the end you will get a final summary. From the final summary, we will get a probable diagnosis with recommended ancillary investigations and recommended blood test.
Ma'am, this ChatGPT പോലെയല്ലേ? ChatGPT imagines answers. Uvioscope interprets evidence. This isn't just AI. It is clinically applied intelligence, like a third umpire, unbiased and precise.
I am Dr. Anju. I built Uvioscope to make uveitis screening better and sharper. A vision beyond tests. Right test at the right time.
One captain and 4 presenters. 5. Captain doesn't present. Non-playing captain. Madam, here. Hello. This Kochi Fire Queens, madam, Ophthalmic Premier League, since I won 90 of them, I will tell you, it is a game wherein you connect to the audience. You are all looking very beautiful, but you are coming and standing as if you are going for a fashion show. Coming and standing there like this and not even talking one word. One word. No, Ophthalmic Premier League, you have to connect the audience and talk to you about the video.
Those are the instructions to us.
Number one, no, I am very confused. Shini, you come here. Shini, you come here. Chandrakant. No, I don't know. This team has to be disqualified. Sir. Very bad. No, judges don't comment now. No. You'll get the votes, don't worry.
Sir, I'm standing for an election.
Yes.
They should be supporting me, but I can't help myself.
Yeah, you can't help it.
I can't help it. No. See, is it permitted for somebody to market their product in OPL?
Yes, sir.
No. Anju! What is this, Anju? And
You can market your surgery, but we can't market the product.
No. And what is the point in studying screen use, man? You know. This is something you all know. What is it?
Yeah.
Hey, what did we learn from that?
Judges, please no. Let them continue the drama. You put the marks.
Judges cannot do anything now.
You want to know more about Paityam?
Anjana.
You learn it from our hero Sujit. And see, Vanasri is such a wonderful surgeon. You should see her hands.
Where are the bouncers?
So
good. All the bouncers.
But see, she went in, poked it. What?
No. Literally, she told us how to remove the posterior capsule beautifully along with the plaque. Very nice, Vanasri.
No, sir. Actually, you have seen the promo video, no? Everybody has seen the promo video. Have you seen any ball hitting their bats? No. They were just showing bats. So same thing was there for their presentation also. I just want to know that last guy who was the patient, unfortunately, why he paid 500 rupees for consultation? He would have an app, correct? And the doctor doesn't know what is the symptoms and so on, all in the app. And one more thing I want to tell was the third one. I don't understand what is the mobile thing was there. And all the thing, I don't connect with ophthalmology. Why mobile was being...
Why? No, it is probably they should have gone to some other hall and
All students...
Correct.
Not in Ophthalmic Premier League.
And then complication, I know.
Yes.
I think better you come to us. We will show you how to put an iris iris hook.
Yes.
Thank you.
Friends, anyway, the most beautiful team in Ophthalmic Premier League history is the Kochi Fire Queens. The most beautiful team.
No, we don't
Let's
want
give a big round of applause.
We don't want beautiful.
No.
You can keep it with you.
Only beautiful.
The best team in Ophthalmic Premier League is Kochi Fire Queens.
Absolutely. Anyway, let's put our hands together for Kochi Fire Queens. And we'll have the next team, Anjana and Sonia. You not introduce the other judges. Introduce all the
Here comes the Travancore Titans, and you know, Travancore is having the richest treasure, and we are coming with the treasure in ophthalmology. Come on.
Kankuru. So I'm presenting a rare case that did not fit the usual pattern. A 56-year-old male presented to me with complaints of itching, irritation and watering left eye. He had a history of herpes zoster. So ഞാൻ കരുതി nothing but an SPK. But there were some unexpected findings. As expected, there was SPK scars, but they were old. But the superior cornea showed some punctate epithelial erosions which were stain positive. That means there is something in the upper tarsal conjunctiva, some foreign body or some pathology. There were no signs of any uveitis. So I decided to evert the upper lid, and on eversion I could see that there was multiple unique button-like elevated pustular follicles with surrounding vascularization. Rest of the findings were completely normal. So as you can see, there were follicles from the medial canthus to the lateral canthus, multiple in number, with intrinsic vascularization, intense vascularization. What type of a follicle is this? Anyways, I started on antibiotic with low dose steroids, frequent lubricants, ganciclovir gel for 5 times, asked him to review in 5 days. On review, congestion reduced, rest same. So I decided to change to Predfort eye drops very frequently. Asked him to review, but no improvement in any symptoms. അതായിരുന്നു എൻ്റെ അവസ്ഥ. So I examined him again, high magnification. There was some unique jelly-like appearance inside of each follicle.
അതിന് എൻ്റെ ഇല്ലാത്ത ബുദ്ധിയിൽ ഒരു ഐഡിയ തോന്നുന്നുണ്ട്.
So I excised those follicles in the OR. They came out just like button-like encapsulated cyst. But one of them accidentally ruptured, and I could see there was a sea of tiny gelatinous pearly cysts that bursted into the surgical site. I took them and I collected them and sent for histopathological examination. On histopathology, there was intranuclear eosinophilic inclusion bodies, multinucleated Jane cells, and lymphocytic infiltrate, which suggests that tiny cyst that bursted, they were actually Cowdry type A bodies, which is very specific for herpes simplex infection.
But why? The coefficient of linear expansion is the position of the hemoglobin in the atmosphere. But why?
But why? I don't know the answer. So I referred him to the physician who started him on valacyclovir TID, followed up of 2 weeks. Several of the small follicles disappeared, large follicles reduced in size. However, the surrounding congestion and vascularization, it was there. There are some central located follicles which significantly caused irritation and watering to the patient. And as we stopped the 2 week of antiviral, some of the follicles started recurring also. One thing I noticed was, in the areas where the follicles were previously excised, they show a smooth healing, minimal fibrotic changes, no signs of any recurrences. So I discussed all pros and cons with the patient, and we decided to excise all the stubborn, persistent follicles. So this time I sought expert opinion with few of the great specialists in this field, and they told few recommendations. After excising the follicles, I applied a betadine bath for 3 minutes. Cornea to be protected with a layer of viscoelastic and a cotton bud. Also, after excision, some of the follicular bed showed prominent vascularization. So I applied mild cautery to these follicular beds. Post-operative follow-up, patient became very happy. However, on discussion with the physician, I continued antiviral therapy for additional of 2 weeks. 1 year of follow-up, patient is very happy. Thank you. So presenting stick seal heal the glue game in diabetic vitrectomy, transporting you to the Marvel metaverse. So complicated diabetic vitrectomy is any VR surgeon's nightmare. Fragile neovascular membranes, recurrent bleeding, high intraoperative visible fluctuality, and high risk of postoperative complications like vitreous cavity hemorrhage. So this is our patient, a 61-year-old female, best corrected visual acuity of 6/60, a combined retinal detachment with vitreous hemorrhage. So this is the other eye, a chronic fractional detachment, best corrected visually of counting fingers, inoperable. So this is a OCT, so right eye, you can see a pre-existing hole near the macula with traction.
superiorly a taut hyaloid with extensive traction, and the traction of the retinal detachment is extending extensively superiorly as well as nasally. So we are getting ready for a battle with all our Avengers superheroes, the cutter, the laser probe, the pick forceps, the scissors and whatnot. So continuing with the 25 gauge pars plana vitrectomy, we have done the core vitrectomy. We are fluting the blood from the posterior pole. You can see the pre-existing break with traction there. So I've continued the membrane dissection meticulously with the help of vitreous cutter. The membranes are very adherent and flat, and one pull to remove the membrane, and I have caused a break nasally. But that is still okay, I can laser nasally. Continued the membrane dissection with the help of scissors. Yes, the blood is getting accumulated. We are fluting the blood at the pre-existing break. Again, with vitreous cutter, another break happened. That is inside the superior arcade. So I am flattening with the help of fluid air exchange. The bleeders have been diathermized, but still some amount of subretinal fluid is persisting in the posterior pole. So what to do to break the seals if subretinal fluid is persisting? So yes, here comes our superhero Spider-Man with his glue. So I have decided to use tissue glue, which is a dual component fibrin and thrombin glue, so which has been used extensively in anterior segment surgeries like pterygium and corneal surgeries. So why not use this too for posterior segment surgeries also? So the breaks which are close to the macula, so I have put the fibrin and thrombin glue. So this mimics the final step of the coagulation cascade. They will provide good tissue support. They act as good sealants. They even can help in hemostasis, and till the subretinal fluid get absorbed, they will seal the break. So yes, they prevent postoperative vitreous cavity hemorrhage, can seal inadvertent breaks, improve hemostasis, staph, minimal allergy and toxic reactions. So we have put silicone oil in advance for additional tamponade. So we have conquered over the Thanos. So this is a post-op day 1 image. You can see there is subretinal fluid, but still the glue is there and the breaks are sealed. So it's a 3-month post-op image. It is a 6-12. Mind you, it is a one-eyed patient. So the breaks are nicely sealed. Retina is well attached. And yes, this is how you conquer a diabetic vitrectomy. So diabetic vitrectomy needs safer, more efficient adjuvant so that we can provide best vision for the patient. Thank you.
Sometimes very routine cases teach us some very important lessons. I'll be sharing 2 such cases. The first case is the wrong turn. So a 49-year-old patient with intumescent cataract walks into the OP. So this was referred by a previously operated patient. He has a mature intumescent cataract and he was advised of phacoemulsification cataract surgery. Since it was intumescent, I planned to do a double rhexis. Initially, a smaller rhexis was done. Viscoadaptive viscoelastic was used and the capsular rhexis was enlarged, and a second rhexis which was encircling the first one was made. The nucleus was emulsified by a direct chop technique. The nucleus was rotated and the other pieces were also emulsified out. The cortex was aspirated and the IOL was placed. The surgery was uncomplicated. The team and the surgeon were happy and celebrating. But unfortunately, on post-op day 1, the patient came with headache. Patient came with shallow anterior chamber, both in the center and in the periphery, and the intraocular pressure was around 35 millimeters. And this was the expression of the patient when I told the diagnosis. So we came to the conclusion that this is aqueous misdirection syndrome, the signs being central and peripheral anterior chamber being shallow with a high IOP, absence of suprachoroidal hemorrhage, and the pupillary block being ruled out. So the main risk factors are shallow anterior chamber, shorter axial length, problems with zonular apparatus, and increased risk in the fellow eye. The patient was managed medically with the injection mannitol and the outcome was pretty good. The intraocular pressure got controlled and the patient resolved in a period of 5 to 6 days. So from the vision problem, we go inward. where a patient presented with uninvited images. So my background of yoga practice helped me with this particular case. It's a 23-year-old patient who was referred to me by a retina specialist. She was diagnosed as retinitis pigmentosa, visual acuity 612, but severely constricted visual fields, and the patient was very disturbed. Why she was disturbed is because of hallucinations. Patient was seeing multiple snakes, worms, and other insects. So her life was very disturbed. The diagnosis is Charles Bonnet syndrome. Charles Bonnet syndrome is a complex visual hallucination where the patient develops this as a compensation for complete or partial loss of vision. The most important characteristic is there is no psychiatric problem in the patient. So the care is always a 3-layered model where the ophthalmologist has to take the lead with visual optimization. There should be psychological counseling. This patient was taught grounding technique where she was taught to touch objects and make out what is real and unreal. And also her family was counseled. We told the family that the patient does not have any psychiatric problem and she has to be supported. So this was supportive for the patient and she was able to restart her college life. Thank you.
So hi everybody, I'll be talking about a unique case. 75-year-old male, decreased vision right eye, best corrected counting finger close to face, no systemic illnesses, and this was a nuclear cataract in the right eye. You can see the color fundus picture. He came with retinal detachment there with a whitish lesion. You can see to the inferior arcade there, you can see that whitish lesion, and you also see the retinal detachment there. So that's why his vision was less. And you can see one lesion which is incarcerated retina and as well as the choroid. There is some minimal vitreous cells which you can see on the OCT. So we did a complete UVA workup for him. Everything was negative. And also the line scan, you can see the break. So did an FFA ICG. Also there is some mild leakage. I was like, what case is this? So I took the patient to the OT under guarded prognosis.
Yes. തല ഇവിടെ അതല്ല തല വെക്കുന്നത് അവിടെയാണോ ഇവിടെയാണോ ഇവിടെ ഓ ആയിക്കോട്ടെ ഭഗവാൻ മിസ്റ്റർ ബരം വൈകിട്ട് എന്താ കഴിച്ചത് പരിപ്പം ഉരുളക്കിഴങ്ങ് റിസ്ക് എടുക്കണ്ട
So after explaining all the risk, took the patient, did a core vitrectomy. You can see that lesion there to the inferior arcade, truncated the vitreous around, pulled the vitreous, removed the adhesion. And so there was an epiretinal membrane, and after staining with BBG dye, removed the epiretinal membrane for the surface. There was already a break and the lesion was just under that. So did the peel under PFCL, did endocautery so that there's no bleeders, and made a retinotomy and removed. You can see that lesion there incarcerated onto the choroid. And then slowly with the max grip forceps I removed. You can see the nice heart-shaped break. I posted this for Valentine's Day in Facebook. Yes, see. Yeah, so removed that lesion, sent it for biopsy. So, but unfortunately, and then after that, did the endolaser and put in the silicone oil, did the silicone oil injection. So, post-op histopathology, did not reveal anything much, just showed that there is some inflammation. And then I just followed the patient up like a routine RD. And then he comes 1 month post-op, and I was shocked to see one retinitis lesion just above the arcade beside that break which I made. And it's also seen on the retinitis, it was probably a retinitis lesion. So my colleagues asked me, how your case is going? Yeah, so they asked me whether did a toxo workup before the surgery. So that was my response. Yeah. So the toxoplasma RD, what you saw there, toxo titers were elevated. So treated the patient with Bactrim, Vislone and azithromycin, and 3 months later planned the cataract surgery with the silicone oil removal. 360 Sinike was there, did the Sinike release. It was done by my dad, Dr. Verghese, he's sitting right there. So pupillary membrane was stripped. And pupil stretch was done. And phacoemulsification was done. The pupil dilated pretty well, and followed by cortex aspiration. And implantation of the lens and silicone oil removal. And intraop, you can see this large area of scarring which is there. And 1 week post silicone oil, his vision improved to 624, retina attached, large inactive scarred area. And this was the line scan what you saw on the OCT. So decently managed, not too bad, vision pretty decent. So I was pretty happy. So tears and toxo, I mean RD can happen in toxo. So this case was little unique because unusual presentation. So I learned something new from this case. Thank you.
എല്ലാവർക്കും സമാധാനമായല്ലോ എന്നാ വാ समाधान आ जाओ बेटा आ जाओ हम तो यहाँ पे है ना आ जाओ दिस इज फॉर द जजेस टू अंडरस्टैंड आ जाओ
टाइम अप Anish टाइम अप ரொம்ப வேதனை உண்டாக்கிய உங்க டீம் இங்க வாங்க Travancore Titans அதே இரு At least they were better than the first team because all of them spoke. They spoke. Now I want to ask Vanashri, please come here. This first Rocky Ducru, she took a class on allergic conjunctivitis. Is this OPL class or allergic conjunctivitis? Such papillae, histopathology. Obviously you will see eosinophils there. What is this nonsense?
Sir, it was a class on general ophthalmology.
General ophthalmology.
The total, this thing was
and
on
also,
general ophthalmology.
Ambika, who did this? I think we are all getting hallucinations now after seeing your presentations. We all go to we are all consulting psychiatrists now. Such a horrible.
So the message was do yoga.
Yes, do yoga. You tell, where is she come?
Intumescent cataract.
Didn't have
not used any app, no.
Apple, yeah.
But it is the era of AI. We have to go ahead, use AI. No, you did general, normal cases which we do every day and showing in OPL. What's the big deal? I was talking about the intumescent cataract. And what about the retina surgeries? I think I just kept on seeing OCT, just the process.
And also, he's more bothered about gas. There, you did, and he forgot to do an investigation.
Don't talk. What sort of retina surgery you are? You see a lesion there, and you are not doing toxotitis, and you are doing surgery for that patient.
He's
and
more bothered about gas.
Such a big hole, like a football it is. Heart shape.
Sir,
yes.
Forget about this kids. Picture abhi baki hai.
Oh, आपका टीम है? Ah.
Sir, it was a fantastic no, sir.
Very good, ma.
Correct. Thank you, sir.
Very good, ma.
So, Titan!
Wait. Let's give a big round of applause to Travancore Titans. Now we have the Malabar Mavericks with us. Super. Good, super is it?
A middle-aged gentleman referred for corneal ulcer management. Doubtful trauma, non-diabetic, no other risk factors revealed. As usual, he also did his bit of smart self-medication with antibiotic steroid eye drops. No surprise, we could retrieve fungal hyphae from corneal scraping. We started him on routine antifungals and reassured him by saying, but something was not working. Ulcer worsened and symptoms worsened. Repeat scraping gave a new insight that it was, oh my God, Pythium keratitis. This is challenge number 1 in this case. Now we started him on specific therapy and waited patiently and watchfully. It was great to see him responding to treatment, and over weeks to months, his infection settled. Now comes the second challenge, giving him vision back. Again, we said, we need to tackle corneal opacity and cataract. He was offered deep anterior lamellar keratoplasty along with phaco with IOL. Phaco done, IA done, DALK attempted, using big bubble attempted, but it failed due to scarred cornea. This is challenge number 3, getting a bare DM and prevent it from getting converted to penetrating keratoplasty.
Thank God I could deliver him the best. Exactly what I promised him.
Sir, double coat ready. Puri kottu vadi, naaladi, kattaladi. Adana anjirthe kelu vasuvana sari. Again undu sir wife hello work. Kadachilalla kaippaniyanu sir.
What actually happened here was that the small amount of residual stromal posterior layer got folded in the middle, exactly in the center. Very unusual situation. Difficult to manage because it is very challenging to remove the sandwich layer, that too in the center. No methods described other than converting to full thickness graft. Before I could say my usual dialogue to the patient, he told me this. This is challenge number 4. No way I can retract from this without coming up with something out of the box. Something not done before. Plan was to go from behind and reach the interface and remove that folded layer. Then replace the posterior layer. This time I can't fail for sure. I could of course reach the layer, divide it, but simply could not remove it either with scissors or forceps. Why not try something different? Need to get this out.
Moidine, aa cheriya cutting eduthe.
Finally, all is well. After more than 2 years of perseverance, and we could achieve a satisfactory result. Sometimes out-of-the-box thinking helps a lot. Thank you for watching.
A 29-year-old male patient came to our hospital with a history of injury to his right eye with a projectile gold piece while working in his jewelry shop. On examination, he had a full thickness corneal tear, iris hole, sectoral cataract. Fundus showed vitreous hemorrhage. Ultrasound, B scan and CT scan showed presence of intraocular metallic foreign body and vitreous hemorrhage. Gold foreign bodies are usually inert. Like iron or copper, they won't produce siderosis or chalcosis and may not cause loss of eye. If there is RD or vitreous hemorrhage, we might go in and do a vitreoretinal surgery. But on that day, the gold price hit 90,000. So we decided to go in and take it out. So I told the patient that I will keep whatever I get from your eye as my surgeon fee. So we proceeded with corneal tear repair and lens aspiration. This part of surgery is done by Dr. Sachin George Matthew. After a nice corneal tear repair and lens aspiration, Dr. Sachin handed over the case to me. After putting 25 gauge vitrectomy pods and entering, I am like, after triamcinolone assisted core vitrectomy, we found our treasure sitting near supratemporal arcade. I enlarged the supratemporal port and foreign body is removed with the help of foreign body forceps. After the gold retrieval, my OT sisters were like, "Sir, we are keeping the gold with ourselves and we are ordering a bucket biryani with it." Then I again entered the eye for endolaser to the supratemporal wound. Post-op period, after 1 week, his visual acuity was 6/6 and N6. He is now planned for secondary IOL.
This is a case about a 45-year-old healthy female who came into my OPD looking like this. Seeing her, I was reminded about the COVID-19 times when we saw plenty of mucor cases. She presented with sudden onset of watering and swelling of the right eye, which was progressing to painful prominence with defective vision. She gave a history of fever and vomiting, and she was on multiple oral antibiotics. On examination, there was inferior dystopia, restricted ocular movements, pupil was mid-dilated, there was local rise in temperature, tenderness, you name it, she had it. In addition to this, periorbital anesthesia and HR raised my curiosity. Looking further, I immediately sent for the labs and scans as I was thinking of an infective enterology. And to my surprise, I saw the MRI having multiple loculated collections in the superior and middle part of the orbit. And these were looking like orbital abscess. Wait a minute, that was not an eschar. On removing the eschar, copious foul-smelling pus poured out. Round 1 of incisional and drainage, we sent it for Gram stain. It turned out to be gram-negative bacilli, and we started her on broad spectrum antibiotics. Vision, pupil, ocular movements were monitored 4th hourly. The total count and CRP were on a raise, so we have to look out for sepsis for her. And ultrasound B scan and fundus examination showed that there was globe indentation and retinal hemorrhages, suggesting that probably there was more pus. Round 2 of incision and drainage. And guess what the bug was? It was Morganella morgagni, and it was intrinsic to amoxiclav. It was a case of orbital abscess. This is the patient on the 10th day. She was improving, and to our surprise, her vision had improved from hand movements to 6, 12, and 18. Now, I was wondering, what could have happened? There you go. There's Rho plus positive. It was a case of chronic dacrocystitis that led to this. So now when I saw her lower lid, there was no punctum, sadly because of the infection. So I decided to do a DCR for her with mini monoca. I tried to insert the mini monoca several times, and then I suddenly gave up. Now what do I do? So I kept thinking, and suddenly an idea came out of nowhere. Come, let's bring in some jugaad now. So here's what you need for that. 6-0 vicryl suture, a 23 gauge ophthalmic cannula, needle holder and forceps of your choice, and of course the mini monoca. Now, how do you begin? Begin by cutting the end of the needle from the suture, secure the mini monoca with the end of the suture. Once that is done, then you gently break off the hub of the metal shaft of the cannula, holding the cannula firmly. Slowly you begin by inserting the 6-0 vicryl into the shaft till you see the other end. Now it's ready to be inserted. Gently introduce the cannula into the canalicus, and you introduce it till you see it at the surgical site. Now at this point, you should make sure that you hold both the ends firmly so that you do not lose it down there, and gently pull it out. So now you have the cannula along with the suture inside. And gently ease it into the puncture, and once that is done, using the suture as the guide wire, you pull it out till it is flush with the puncture. This is the journey of the patient. This is her on day 3, day 10, and day 7 post-DCR. And this is her today after 1 month. We remove the mini monoca for her, and she's syringing patent. She's not Morganella, she's Morgan Freeman.
My son saw this video on YouTube, and he also wanted to be rescued from a cliffhanger situation. So he is somebody who has been helping me win OPLs in different states across India.
We will use this technique to win the OPL.
So I decided, okay, I'll show videos where I've saved IOLs from dropping those which are actually on the way down. So this was IOL bag, CTR complex progressively going down because of progressive pseudoexfoliation. Everything was taken on and was replaced by lens of my choice for these situations. The iris color lens, I've done thousands, and it's really worked well in my hands. Gives around people.
Your last case was great. I believe in the next one.
So this was brought to me by junior. He said, sir, I couldn't enclavate one haptic, and please help me. So I thought, you just manipulate the other haptic, will come up. And I kept up pressing it down. It's not going in. See, there is no split there. There is no claw. So this was the problem. But if the IOL is okay, then you can just manipulate it, bring it up, and just press enough iris down onto the claw, enough iris tissue gets enclavated, and it remains stable. So that is what was done in this case. Yeah.
You did great.
So this case, so it's almost down there. I didn't want to touch it. I didn't want to be in a situation where Salon couldn't try to help Jane, and she fell down. So I decided I'll refer it to my retina colleague. That was my decision. I just looked at it, and he said,
don't even think about it. You can do it.
Okay. Then I decided, okay, I'll go in, take it out. Iris claw, no. I'll use the same lens. One haptic was railroaded out, and this end was cauterized, and that's it. it gets fixed there. The same thing on the other side, the haptic taken out, cautery done, flanged. Yes, it stays stable. So this patient came to me 3-4 years after surgery, no trauma, no pseudoexfoliation, subluxation, about 180 degrees, zonal dialysis. So it is 180 degrees. I thought I'll put a ring segment but you could see what happened. I was trying to fix one area and the other area came out. It's like trying to save one and you're causing more trouble there. So I didn't have another ring segment. Called the patient after some days and another ring segment was put. You have to be careful when you pull it there because the other flanged area should not come out. And this area was also flanged and the IOL is stable and well centered. You can see post-op.
My father is the best. Make his team the champion.
Yeah!
Malabar Mavericks. Anish, these guys, I don't know how they are practicing in Kerala. Where is the president, Rajesh Sukumar? How do you allow these butchers to practice, man? They are either shoving something inside the eye or taking it out. Every surgeon is doing it. Every player was doing that. And gold, I will tell you, Nikhil, the patient is coming with a big corneal tear and you have produced a big scleral tear also. Double, because he paid gold, no, he paid gold, no, double. So, very simple, you have already done phaco. Do a posterior capsulorhexis. You could have taken the gold through the limbal route and taken the gold away. But was it 24 karat, 22 karat, or 18 karat? That you didn't mention. Yes.
Sir, easy,
Yes.
sir. Sujit is there, no? They will take the cornea out. Then he will put the cornea back.
Yes, sir.
Then they will suture.
Suture.
Ha.
Then they'll put it inside, take it out. Put it inside, take it out.
My father is the best.
Malabar! Hey, actually, the best player was your son.
Yeah.
Yes. Was your son, he is better than you. We'll give you all the votes, but don't participate in OPL.
He actually, probably sir's only defeat in an OPL was because of my son at Telangana.
Varangal.
Yeah.
Anyway, let's put our hands together to the Malabar Mavericks for you guys and final team. The team, we are looking forward. Wonderful costumes as well, Wallo Nut, Falcons.
എല്ലാവരും ഉറക്കത്തിൽ നിന്ന് എണീറ്റോളൂ. Till now you have been seeing the reels and class presentations. Now let's watch the real movie, Sit Back and Relax. Presenting Walluvanad Falcons.
Dr. Samyukta, leading VR surgeon from Chicago. Fazrak Ravi Master, Walluvanad's guardian of sight. Dr. Niranjana, first doctor from her community. Dr. Prakash Proli, fitness and glaucoma guru from Texas. Dr. Era Qureshi, lead AI scientist from Beijing. What holds them together is destiny. The legend begins.
ഓ ഹായ്, അമ്മൂമ്മയ്ക്ക് എന്താ കാഴ്ചക്ക് പ്രശ്നമുണ്ടോ?
കാഴ്ച കുറവാ. ഡോക്ടറെ കാണണമെങ്കിൽ 60 കിലോമീറ്റർ ദൂരെ പോണം.
രോഹൻ സർ, ഇതെങ്ങനെയാ സ്റ്റാർട്ട് ചെയ്തത്? ദിസ് ഹോസ്പിറ്റൽ ഇറ്റ്സ് സോ നൈസ്.
ഖസാക്കിൽ ബസ്സിറങ്ങിയ രവിയെ പോലെ എന്ന് പറയാം. രവിയുടെ ഏകാധ്യാപക വിദ്യാലയം പോലെയാണ് ഞാൻ ജോയിൻ ചെയ്ത ഗവൺമെൻറ് ഹോസ്പിറ്റൽ എനിക്ക് തോന്നിയത്. കണ്ണു നോക്കാൻ ഒരു ടോർച്ച് മാത്രമുണ്ട്, പിന്നെ കേടായിപ്പോയ ഒരു ഒഫ്താൽമോസ്കോപ്പ്. ബാറ്ററി നന്നായി ഒന്ന് തിരിച്ച് തലയിൽ ഒരു മേട്ടം മേടിയാൽ ഒരു കുഞ്ഞു ലൈറ്റ് തെളിഞ്ഞു വരും. ചിലപ്പോൾ ഫണ്ടസ് കാണും. സർജറിക്ക് സൗകര്യമുണ്ടോ? കൺകുരു കീറാൻ പോലും ഉപകരണമില്ല.
ഇത്രയും വലിയ ഗതികെട്ടവൻ ഈ ലോകത്ത് വേറെ ആരെങ്കിലും ഉണ്ടാവും എന്റെ കർത്താവ്.
നാട്ടിലേക്ക് തിരിച്ചു പോയാലോ? സൂപ്രണ്ടിനോട് പറയാം. പറഞ്ഞതെല്ലാം നിർവികാരനായി കേട്ട് ഒന്ന് പുഞ്ചിരിച്ചു. ഇവിടുന്ന് പോയാൽ നീ എവിടം വരെ പോകും? സർക്കാർ കാര്യം എല്ലായിടത്തും ഇങ്ങനെ തന്നെയാ. അങ്ങനെയാണല്ലേ? ഞാനത് മാറ്റിയെടുക്കാൻ നോക്കും. അതൊരു ഉറച്ച തീരുമാനമായിരുന്നു. പിടിപ്പത് ജോലി. അതിനിടെ വളരെ പ്രയാസപ്പെട്ട് ഗവൺമെന്റ് ഫണ്ടുകളെ കുറിച്ച് പഠിച്ചു. റിക്വയർമെന്റ്സിന്റെ അപേക്ഷ ഓഫീസിൽ കൊടുത്തു. കൊട്ടേഷൻ സംഖ്യ കേട്ട് ക്ലർക്ക് വാ വിളിച്ചു.
പോയിന്റിലോട്ട് വരാം.
ഇത്രയും ഫണ്ടോ? ഇത്ര ഫണ്ട് കിട്ടിയിരുന്നെങ്കിൽ പ്രസവ വാർഡ് നന്നാക്കിയാനെ, ടോയ്ലറ്റുകൾ പുതുക്കിയാനെ. ആകെ 4 ആള് വരുന്ന ഐ ഡിപ്പാർട്ട്മെന്റിന് ഇത്രയും ഫണ്ട് എന്തിനാ? ഓഹോ, എങ്കിൽ നോക്കാം. 400 ആക്കി തരാം, പോരെ? ഖസാക്കിന്റെ ഇതിഹാസം ഈയിടയ്ക്കും വായിച്ചതാണ്. തസ്രാക്ക് എന്നെ മാടി വിളിച്ചു. ഞങ്ങൾക്ക് കാഴ്ചശക്തി തരൂ. കയ്യിലെടുക്കാവുന്ന നേത്രപരിശോധനാ സംവിധാനങ്ങളുമായി തസ്രാക്കിലെത്തി. പുറത്തെ കണ്ണിന് മാത്രമല്ല, അകക്കണ്ണിനും കാഴ്ചശക്തി അത്യാവശ്യമാണ്. രോഗികളുടെ നിരയിൽ ഇഷ്ടകഥാപാത്രങ്ങൾ: അള്ളാപ്പിച്ച മുല്ലാക്ക, അപ്പുക്കിളി, മൈമുന, നൈസാമലി. എല്ലാവർക്കും പലവിധ കണ്ണുരോഗങ്ങൾ. രവിമാഷിന്റെ വിദ്യാലയമല്ലേ, ആശുപത്രി കാര്യങ്ങൾ എല്ലാവരോടും വിശദമായി പറയാം. ആശുപത്രി എല്ലാവർക്കും പ്രയോജനപ്പെടട്ടെ. നമുക്കും അതാണ് വേണ്ടത്. മുല്ലാക്കയുടെ തിമിരം മാറി. നൈസാമലിക്ക് കണ്ണിലെ ഞരമ്പിലാണ് കേട്. അതിനിവിടെ ചികിത്സയില്ല. അവൻ സങ്കടത്തിലായി. ഡോക്ടറെ, നിങ്ങൾ ചികിത്സിച്ചാൽ മതി, എൻ്റെ അസുഖം മാറും. വേണം. അവനെപ്പോലുള്ള റെറ്റിനോപ്പതി രോഗികൾക്ക് ഇവിടെ തന്നെ ചികിത്സ കൊടുക്കണം. OCT, ലേസർ, ലക്ഷങ്ങൾ ചെലവുണ്ട്. ഫണ്ട് എവിടുന്ന് കിട്ടും? പാലക്കാട് ജില്ലാ പഞ്ചായത്ത് അത് ഏറ്റെടുത്തു. റെറ്റിന ഡിപ്പാർട്ട്മെന്റ് റെഡി. APJ അബ്ദുൽ കലാം സാർ പറഞ്ഞതുപോലെ കുന്നോളം കൊതിച്ചാലേ കുഞ്ഞിക്കുരോളമെങ്കിലും കിട്ടും. എന്നാൽ ഞാൻ ഇന്ന് ഒരു കുന്ന് തന്നെ സ്വന്തമാക്കിയിരിക്കുന്നു. അമ്മയെ കാണാൻ കൊതിയായി. നാട്ടിലേക്ക് ഓടി. എന്റെ മുഖത്ത് നിന്ന് അമ്മ മനസ്സ് വായിച്ചെടുത്തു. എല്ലാം നേടി എന്നൊരു ചിന്തയുണ്ട് മോനെ നിനക്ക്. പാവപ്പെട്ട ഒന്നുമില്ലാത്തവന് നീ എന്ത് നൽകി? അതിന് സാധിച്ചാൽ നിനക്ക് ശാന്തി കിട്ടും. ജില്ലാ ആശുപത്രിയിൽ റെറ്റിന സർജറിയാണ്. പരിഹാസച്ചിരികൾ കാതിൽ മുഴങ്ങി. ഇതും ഞാൻ നേടും.
ഇങ്ങനത്തെ പ്രതിസന്ധികൾ ഉണ്ടാകുമ്പോഴാണ് യഥാർത്ഥ നായകന്മാരുണ്ടാവുക.
ഉറക്കമിളച്ച് പ്രൊജക്ട് തയ്യാറാക്കി. വാശിയോടെ ചെയ്യേണ്ടതെല്ലാം ചെയ്തു. ഓടിത്തളരുമ്പോൾ അമ്മയുടെ, മുല്ലാക്കയുടെ, അങ്ങനെ ഒരുപാട് മുഖങ്ങൾ. പൗലോ കൊയ്ലോ കാതിൽ ചൊല്ലി, കാര്യം നേടാൻ നീ അതിയായി ആഗ്രഹിക്കുന്നെങ്കിൽ ലോകം മുഴുവൻ നിന്നോടൊപ്പം ഉണ്ടാവും. അങ്ങനെ അതും നേടി. ജില്ലാ ആശുപത്രിയിൽ റെറ്റിന സർജറി. തിമിരം നീക്കിയെങ്കിലും മുല്ലാക്കയ്ക്ക് റെറ്റിന ഡിറ്റാച്ച്മെന്റ് വന്നിരുന്നു. സർജറിയും കഴിഞ്ഞ് കാഴ്ച തിരിച്ചു കിട്ടിയ മുല്ലാക്ക എൻ്റെ കൈ പിടിച്ചു പറഞ്ഞു, സാറ് കാഴ്ചയുടെ പടച്ചോനാണ്. തസ്രാക്ക് മുഴുവൻ അത് ഏറ്റു ചൊല്ലി, കാഴ്ചയുടെ പടച്ചോൻ. ആ പ്രശംസയിൽ പക്ഷേ കണ്ണു മഞ്ഞളിക്കുന്നില്ല. കാവശ്ശേരി പഞ്ചായത്ത് തിമിരമുക്തമാക്കാൻ തീവ്രയത്ന പരിപാടി. അതെ, ഈ പട്ടിക അപൂർണമാണ്, എന്നാൽ ഇത് അപൂർവവുമാണ്.
പിന്നെ കാണാം.
കഴിഞ്ഞ 1 വർഷമായിട്ട് എൻ്റെ കൂടെ ഒരു ഡോക്ടറോട് ഇപ്പം ജോയിൻ ചെയ്തിട്ടുണ്ട്.
സൗന്ദര്യം വഴിഞ്ഞൊഴുകുന്ന അമ്മ പെങ്ങന്മാരെ, എൻ്റെ ആരാധകരെ, ഞാൻ പാടുന്നതിനിടയ്ക്ക് പൊന്നാട, ജണ്ട്, റീത്ത്, ഹാരം, നോട്ടുമാല, നാരങ്ങ എന്നിവയൊക്കെ നൽകി എന്നെ സ്നേഹം കൊണ്ട് വീർപ്പൂട്ടിക്കരുതേ എന്ന് ഞാൻ അപേക്ഷിക്കുകയാണ്. ഞാൻ തുടങ്ങട്ടെ.
In the beautiful land of Valluvanad, one fine October morning, a 55-year-old female came to us with the complaints of watering, photophobia and blurring of vision both eye since 3 months. She had a history of night blindness since adolescence. She also gave a history of irritable bowels and steatorrhea for the last 30 years. She had consulted multiple doctors in the past and was on and off medications. She had a mixed diet and her BMI was 25. On examination, her best corrected visual acuity was 6/12 in right eye and 6/9 in left eye, Anterior segment showed severe dry eye, conjunctiva was dull and wrinkled, cornea hazy and lusterless with punctate erosions. Fundus showed multiple small yellowish-white retinal lesions sparing macula with a vertical cup-disc ratio of 0.4. Visual field examination revealed tubular fields. A clinical diagnosis of Guimara syndrome was made, keeping in mind the differential diagnosis of retinitis punctata albicans and fundus albipunctatus. Gastroenterology workup revealed fat malabsorption secondary to small intestinal bacterial overgrowth after ruling out inflammatory bowel disease, liver and pancreatic causes. Patient was started on vitamin A and D supplements together with systemic antibiotics and probiotics. 2 weeks later, the best corrected visual acuity improved to 6/6, tear film improved, conjunctival cirrhosis disappeared and cornea regained its luster, but the fundus lesions persisted. She was advised regular vitamin A supplementation for 3 months, following which the retinal lesions started to fade and visual field showed improvement. Once the patient was symptomatically better, she was not keen at follow-up anymore.
Hello? What?
One eternity later.
After 10 months, when the patient finally came for review, the retinal lesions had completely disappeared, but the field not fully recovered. Guimara syndrome or xerophthalmic fundus is seen in patients with chronic vitamin A deficiency. It should be suspected in adults with night blindness and RPA-like retinal lesions, especially when the anterior segment findings coexist, and should prompt for malabsorption workup. Root cause should be evaluated and supplementation continued even after the reversal of anterior segment findings. While early diagnosis and treatment can reverse the field effect, prolonged deficiency can result in irreversible damage to photoreceptors.
Sir, അമ്മൂമ്മ നല്ല ഹാപ്പിയാണ്.
Thank you.
ഈ സെന്റർ നമുക്ക് കുറച്ചുകൂടി നന്നായിട്ടൊന്ന് ഡെവലപ്പ് ചെയ്തിട്ട് ഒരു ഇന്റർനാഷണൽ ലെവലിലേക്ക് നമുക്ക് എത്തിക്കണം.
അതിനുവേണ്ടി നമുക്കൊരു പ്രൈവറ്റ് പബ്ലിക് പാർട്ണർഷിപ്പ് ആണ് ആവശ്യം.
അതിന്റെ കൂടെ റിസർച്ചും AI ഇന്റഗ്രേഷനും കൂടി ആഡ് ചെയ്താൽ നന്നായിരിക്കും.
Okay, I can help you. Hi, Jan.
Hey Sam, what's up? Long time. Sounds interesting. Okay, see you soon.
Okay.
Hi everyone, my name is Mr. P. I come from a legendary family called the Sutures, known for holding things together in the world of glaucoma surgery. My cousins are star too, Mr. Weichel, Miss Nylon and Miss Silk, each with their own signature moves in the operating room. But I always dreamt of doing something bigger, of making my mark in glaucoma surgery. One fine day, a few kind surgeons from Texas noticed my potential. They invited me to join them on a new adventure, the world of minimally invasive glaucoma surgery, which was dominated by Mr. Stent, Mr. Blade and Miss T.
നിന്നെ രക്ഷിക്കാൻ ആരുണ്ടടാ?
After days of simulation eyes, patient selection and micro-maneuver drills, I finally felt ready to leave the shelf, enter the eye and see the real world for myself. My first real mission was a young lady with advanced juvenile open-angle glaucoma. Her pressures, a mighty 34 millimeters of mercury, and even the drops had dropped out of ideas. Under a bright surgical light, I finally entered the battlefield, the anterior chamber. Guided by gentle microforceps, I traveled a full 360 degrees around the trabecular meshwork and came out victorious. Pressure down, surgeon smiling, mission accomplished. Since then, I have learnt a few pearls worth sharing.
நோட் பண்ணுங்கப்பா பின்றாம்பா.
Stab entry with MVR angulated towards the nasal angle. Avoid limbal blood vessels to decrease blood over cornea. Treat only what you see. A little heme reflex? That's good. Means you hit the right spot. And remember, in MIGS, steady hands, much more important than fancy gadgets. That's when I found my true calling. Over the years, I have helped many primary, steroid-induced, even post-vitrectomy glaucomas. My recent achievement was when I helped a gentleman with post-VR surgery glaucoma with uncontrolled intraocular pressure and was planned for glaucoma implant surgery. A quick intraop assessment of angle showed that there was a chance for performing trabeculotomy. After a successful 360-degree passage, I could create a good cleft in the trabecular meshwork, and the patient achieved a post-operative IOP of 16 millimeters of mercury at 1 week. My strengths: easy availability to achieve a 360-degree trabeculotomy, being conjunctiva friendly, and a simple learning curve. And my biggest virtue: affordability. My dream now? To travel across Africa, where glaucoma is common and costly care isn't easy to find. Maybe there, I can help surgeons stitch a few more success stories. See you soon in your operating theatre.
Hi, Ira. Who are you? Okay, we will do it. Thank you.
With her wizardry and the force of AI at her side, Dr. Qureshi reshaped Balubinad Hospital. Now, together, we open the portal and enter the world she has created.
I am Dr. Era. Let's see how we have transformed the clinic at Balubinad with the help of AI. Our relation with you starts at your home while you fix your appointment. Through your personalized AI-based app, the Clarity AI, with this interface, all your details gets updated into your profile in real time as you proceed through the hospital. Registration, refraction, or consultation, be it anywhere. No queue, no waiting, guaranteed. This is ensured by minimal human interface with automated kiosks and pods. Currently, fund us on phone. The FOP does diabetic retinopathy and glaucoma screening. More diseases are getting added to the list. With the help of AI-based Hear You app, you can be rest assured that your doctor is fully attentive to your complaints, while Hear You does what it does better. History taking by the end of examination, patient details gets updated in Clarity APP. The Clarity app also has AI-derived patient awareness programs, including songs and brochures created with Gemini AI and Suno AI. In the field of surgery, AI-based calculations and robotic surgery ensure predictability, precision, and consistency. Those are the nanorobots working on the eye. Check those tiny monsters at work. Even when the surgeon and the surgery becomes AI or robot-based, the patient is still human, and in glaucoma surgery, the biggest challenge is to get that desired IOP. In the next phase, we are planning to incorporate AI in research and development at Balubinad, and currently we are working with Easy Tap, easy to adjust pressure, a device where we can actually control the aqueous outflow as if controlling water flow from a tap.
ഈ ബുദ്ധി നേരത്തെ തോന്നാത്തത് ഓരോന്നിനും അതിൻ്റെതായ സമയമുണ്ട് മോനെ.
The AI-based classrooms will be centers of research and innovations. The mentees will work on the 3D printed models of latest advances. While AI is set to transform our R&D, our mentees will continue to participate in physical CMEs conceptualized and materialized with the help of AI to get inspiration and to maintain that human touch in this virtual world.
As the President Ksos said, AI is here to stay. Those who adapt will lead, and those who don't will have to leave. A small village at Balubinad is now an international ophthalmic hub for research and training. The World Ophthalmic Council now looks to this remarkable public-private partnership model As the future of eye care in underserved and remote communities worldwide, we present Kerala's eye care model to the world.
So how was the movie? That's Team Valunad Falcons. Thank you.
Come on, Samira. I am totally confused. Rohan, அது மலையாளம் டாக்குமெண்ட்ரி ஆக்கம் உங்களுது ஃபுல்லா மலையாளம் டாக்குமெண்ட்ரி ஆட்டம் இருந்துச்சு. ஆமா. No, that was a Malayalam documentary movie. That what Rohan showed. Yes. But nothing else is there. What is the use AI app? What is there? Absolutely, only the costumes are good. Excellent costumes. Any mark for the costumes, judges? Anyway, yeah, costumes are good. No, because they especially this costume is very good. Yeah.
She's a wizard.
Yes.
She's a wizard. You see the AI what they have
No,
done.
Anish. No, Anish and come. Vanishri and Kala baby come.
മോഹൻലാൽ പറഞ്ഞ പോലെ നിങ്ങളെ രക്ഷിക്കാൻ ആർക്കും പറ്റൂല. ശരിക്കും പറഞ്ഞാൽ എനിക്ക് സംശയം എനിക്ക് വട്ടായതാണോ ഇവർക്ക് മൊത്തം വട്ടായതാണോ ഒന്നും പിടിയില്ല.
ഒരു സംശയമില്ല സാർ ആർക്കാണ് വട്ടായത്?
ഇവിടത്തെ സ്റ്റേജ് മൊത്തം കത്തിക്കുമെന്ന്.
ഇല്ലല്ല, ആ സ്പാർക്ക് ഒന്നും കത്തിക്കാൻ പോരാ. അണ്ടർ എസ്റ്റിമേഷൻ പാടില്ല സാർ.
എന്റെ പൊന്നു സാറേ, സാറിന് ഇത്രയും ദാരിദ്ര്യമാണ്.
So till now you are watching reels, like, you know, if you have to see all those surgeries, you can sit in any of the sessions. When a movie is expected, this is what is expected. How you transform a community health and make it an international center of excellence.
Absolutely.
And that's what we came together with.
No, that is how you transform everybody with confusion.
Yeah. Sir,
complete confusion.
Sir, when movie is made,
Yes.
we are targeting a larger population. So here there's not the judges. We are targeting a larger population.
Hey, Rohan actually is confused. He was planning to send this movie for an audition. He's just showing his acting skills.
Yes.
Hey, Anish.
ഗോവ ഫിലിം ഫെസ്റ്റിവലിൽ നമുക്ക് അയക്കാം.
Acting is nothing but reacting.
And that says it all. If our movie is that good that it's going to go for a film festival, I think the audience knows whose is it. Yes.
അല്ല, ഇത് ഫിലിം ഫെസ്റ്റിവൽ ആയിരുന്നു അറിയില്ലായിരുന്നു. ഐ ആം റിയലി സോറി.
Sir, even the mimicry artists can change their voice. So you cannot tell that I am not talking that.
Not.
ഇത് നമ്മൾ
You talk, sir. You talked everything. Only things I didn't understand anything.
ഇത് നല്ല സിനിമ അല്ല, നല്ല ഡോക്യുമെന്ററി ആയിരുന്നു. നല്ല ഡോക്യുമെന്ററി ആയിരുന്നു. ഞങ്ങൾ എല്ലാവരും അതിന്റെ കൂടെ. ഒഫ്താൽമോളജി മാത്രം കണ്ടില്ല, അത്രേ ഉള്ളൂ. ബാക്കിയെല്ലാം കണ്ടു.
നല്ലൊരു ഒഫ്താൽമോളജിസ്റ്റിനെ കാണിക്കൂ.
മാഡം കണ്ടു. ഞാൻ ഇപ്പോഴാണ് ഒരു ഒഫ്താൽമോളജിസ്റ്റിനെ ഈ കോളത്തിൽ കാണുന്നത്. സോറി, ക്ഷമിക്കണം. വരരുത് ഈ വേഷത്തില് പ്ലീസ്.
സ്വപ്നത്തിൽ വരും.
இது எவ்வளவு நேரம் இந்த காஸ்டியூம்ஸ் உங்களுக்கு இருக்கும்? How long you will be wearing this? Banquet also? Special lasting impact.
മാഡം, എന്ത് പ്രോബ്ലം ഉണ്ടെങ്കിലും ഞങ്ങൾ അംബിക മാഡത്തിനെ കാണൂ. യോഗ യോഗ
യോഗ യോഗ യോഗ യോഗ യോഗ
hallucination.
App yoga.
Sir, yoga
that's a message for all the OPL. Anyway, let's put our hands together for Valunad Falcons.
AI is here to stay.
Samira, well done. Friends, we have come to the end of this wonderful OPL. I think all the 4 teams were really fantastic. Now, it's heartening to see a packed hall. Not even one seat is vacant. There is a packed hall. A big round of applause for the delegates as well. Judges, please give the, Bastian, please come over and give the awards. Yeah. They'll correct that. I think we have while we are formulating the results. I will take another 2-3 minutes. Please wait in the hall and please encourage and give cheer all the contestants. I want all the players to come here. All the players to come here. Huh? Audience poll, yes. All the players to come here. Yeah, please. Yeah. Do it here. All the players to come, the respective teams. Srini, come. Travancore, Malabar, Valluvanad, Kochi, please come. Stay together.
Good evening all. We have some announcement of some of the competitive awards
Very good.
in Drishti 2025.
Very good essay.
Professor K.S. Subramaniam PG Free Paper Award Semi-Final 1. The selected papers in the semi-finals are Free Paper 101, Comparative Study between Magnocellular Stimulation and Occlusion Therapy in the treatment of amblyopia. Chief and presenting author, Dr. Grishma Marin Sebastian. Free Paper 109, Human Ocular Dyelophyrealiasis, Emerging Zoonosis in Eye and Orbit. Chief and presenting author, Dr. Sanju Shankar. Semi-final 2, Free Paper 93, Tactile Resolution in Eye Drop Management for the Visually Impaired. Chief and presenting author, Dr. Nafisatur Misriya K. Second, Free Paper 88, Analysis of OCT, RNFL thickness and minimum rim width in myopic tilted discs and suspicious cuff. Chief and presenting author, Dr. Pooja Subru M. Subramaniam PG Free Paper Award Session 3, Free Paper 94, Cataract Screening, Validation of Portable Slit Scope for Grading Nuclear Sclerosis in Outreach Camps. Chief and presenting author, Dr. Safira K. Free Paper 106, Clinicopathological Patterns and Surgical Outcomes in Periocular Basal Cell Carcinoma. Chief and presenting author, Dr. Parakal Bhuvaneshwaran Bhuwana. The COC RedNet Posterior Segment Free Paper Award Session. The winner is Free Paper 129, Various Biomarkers for Poor Response to Intravitreal Aflibercept Injection, a retrospective study. Chief and presenting author, Dr. Mradula Gangwa. Dr. K.C. Shankaramenon Free Paper Award. The winner is Free Paper 96, Outcomes of Socket Reconstruction Involving Multiple Surgical Interventions. Chief and presenting author, Dr. Marian Poli. Dr. S. Mohandas Free Paper Award Session. The winner is Free Paper 42, IOPIN in Premature Infants, What is Normal? Chief and presenting author, Dr. Natasha Radhakrishnan.
Superb, congrats.
Dr. Noel Moniz Anti-Segment Award Session. Winner is Free Paper 128, Evaluation of the Safety and Effectiveness of Sub-400 Protocol in Corneal Collagen Cross-Linking. Chief and presenting author, Dr. Sujit Nayanar. Padma Shri Dr. S. Tony Fernandez Video Award Finals. The winner is Video 10, When Risk Meets Reward, the SLED model, SLED miracle that defied odds. Chief and presenting author, Dr. Sujit Nayanar. TACO poster. The winner is poster numbered 76, Feel, Identify, Instill the Tactile the Way. Chief and presenting author, Dr. Aditya Surendran. Thank you.
Okay, Bastin, over? Yes. I think we should acknowledge the support given by Zivira Pharmaceuticals for the wonderful OPL. They've been supporting the Tamil Nadu ophthalmic OPL also for the past 10 years. So don't forget the Zivi Fresh, Zivi Mox and Envisa. Zivi Fresh, please repeat. Zivi Fresh, Zivi Mox, Envisa. Thank you. Luteins here, Santin, Envisa. That's all. Okay. And now we have the Bastian, please come. Anjana and Sonia. Please come over and shall we have the audience poll for the best entertainer? Starting from this side. Starting from this side, Sheeni, Anju, Nikhil, Sujit, Sabna, Samira, but you are a captain, yeah. Yeah, Mahesh, Rohan, Jayashree, Anish, Shishir, Ambika. Come on, I want some this thing, no? Jayashree and Indu Nair, yeah. Anju, Banashree, yeah, and Natasha. Best Entertainer Award. Jayashree. Jayashree, give a big round of applause for Jayashree. I think the costumes, she really killed with the,
Sir,
yeah.
we have arranged this Kahoot thing for a unanimous voting system.
Yeah.
Okay.
Oh, voting system.
Yes, we have
Very
arranged.
good. Be careful.
Okay. So, are you all ready with your smartphones? Kindly take out your smartphones, please.
Yeah, on screen.
So there is a QR code there, QR code. Kindly log in or kindly scan the code so that you can. Okay.
For 10 minutes.
Or some people on the stages are trying to vote. That's not available. That option is not available. It's only for the audience. So are you all ready with the scanning? If you have any difficulty in scanning, there's a number. You can type the game pin 91128 and 54. That's a game pin.
Oh, something else is coming here. They're not joining, okay.
The game has not yet started, sir. The poll is not yet
People
started.
are joining.
Who all is ready? Can you raise your hands? Yeah, I think majority is ready. Okay.
Still joining.
How many joined?
Little more time.
Still more time. Please join. 100 have joined. I think it's anybody having any difficulty? How many have joined, sir? $123, $124. Yes, more people is coming up. Yes, I think it's enough number, no? Can we start? Say yes or no? Yes. Okay. Can I have the first poll, please? Yes. Start, please. So the first poll for this OPL 2025 for the best promotional video. So you can select your best promotional video. Yes, please turn around so that they can have votes without any confusion.
Judges can't vote this also.
So Malabar Maverick, team captain, please raise your hand. Malabar Maverick, yes sir. Vallavanar Falcons. I think it's a confusion is clear, no? Yeah. Everybody is voted. Yes, the team is Travancore Titans. Give for round of applause. Yay! Don't show the full excitement here. The crisis is not yet over. Can we have the next poll? Okay, we can have the gifts. Mohan sir, kindly give the gifts for the best promotional video. Audience, Paul. Anish sir. Namrata madam, can you please come to the stage to all the judges. Okay, people have already voted for the best scientific presentation. These names have been put forward by the team captains only. So I think the best scientific presentation from the audience poll goes to Dr. Suchit from Malabar Maverick. Can we have the gift? Audience, ready for the next poll? Yes. Can we have the next poll, please? Who was the best entertainer? Again, the names were given by the team captains. Dr. Srini, Dr. Vanasri, Dr. Sabna or Dr. Dakiti Cruz. Please vote for your favorite best entertainer of the day. Dr. Rakhi, no wonder. Can we have the gift for Dr. Rakhi? Yes, I think we can also announce a runner-up. Who was that? Dr. Sabna. There's a prize for runner-up too. Dr. Sabna Sashidharan. Yes, for the last poll, can we have the polls? Who is the best team? Vote for your best team. Meanwhile, we'll have to give a memento to our dearest Mohan Rajan sir. I request Dr. Bastin sir to give a memento to our dearest sir for giving us such a fun-filled show. Thank you, sir. moment of truth. The best team, Travancore Titans. Can we have the gifts for Travancore Titans? I think they have the huge ground support.
Three cheers to Ksos. Hip hip. Hip hip. Hip hip.
Audience, please don't leave this hall as we have to announce winners of photography and reels competition after this event. So please stay back. So now it's the time for the judges' result. We have the eminent judges from across our country. So please don't leave this hall. We'll have to wait for the results. Are the results ready, madam? Yes, yes. The results are being ready because it was a tough competition, right? Even though they have bagged many prizes, I think we should appreciate the other people too because they have done a very wonderful job. So much time in dedicating the editing, video presentations and all, right? Please give them a big round of applause. Yes. I will never forget the judges because it is very difficult. Even as an audience, it is very difficult to find out a runner-up or a winner. And you guys, with no bribes. Oh, absolutely with no bribes. Yes, yes. That has to be highlighted, madam. With no bribes. Yes. I think they are having a huge tough time finding, even the tabulating the mark sheet. So we should really appreciate the judges again and again. And it was such a fun-filled show, right? Even for a moment I doubted whether it is OPL or some big boss happening there. It was a mini big boss happening off stage too, right?
I think I must make a comment on the OPL in Kerala. I think it is totally different. The way you all do it, much more professionally than what even the original OPL was done. And everything is so well integrated on time, except the judges' results, which is not on time, but really done very well, very professionally, using all the AI and everything. So many congratulations to all of you. You really worked hard.
So meanwhile, we can announce the winners and runner-ups of the photography competition. It was done as an online competition in Ksos online platform. Many of the photography reels enthusiasts have already participated. It was categorized into street lamp photography, nature photography. I mean, 5 or 6 categories were there. I think Bastin sir is ready with the result. We can we have the results, sir?
Yes, yes.
Yes, over to you, sir.
So these are the results. External photography. The runner-up is it's a tie between Dr. Rani Bala Murali Krishnan and Dr. Prithvi Chandrakant.
Congratulations, Dr. Rani and Dr. Prithvi.
So we'll give prize only for the winner. Okay, the winner is Dr. Sujit Narayana.
Dr. Sujit, yes, he's on the stage. Wow, congrats, sir.
Sujit, external photography.
The prize for external photography, Dr. Sujit Nayanar. I request Dr. Prashant sir to please hand over the prize to Sujit Das. Sujit sir, please.
Now coming to the wonders photography. The runner-up is Dr. Shishir Varghese.
Runner-up, Dr. Shishir.
And the winner is Dr.
Mridula. Please come on to the stage. Dr. Mridula Gangwar. Madam, kindly give the gifts. She's coming, she's coming. This way. This is the winner. Yes, congratulations, Dr. Mridula. Please come forward to collect your prize.
Nature. The runner-up is tied between Dr. Sharath and Dr. Aparna. This is a joint winner. One is Dr. Suresh Nayanan and one is Dr. Sujit Nayanar again.
Yes, multiple prizes.
Dr. Rohan
Suresh, anywhere here? Yes.
The runner-up in the people category, Dr. Avangushi Philamazin. And the winner is Dr. Suresh Nayanan.
Dr. Rohan, right time to be on the stage, first prize. Two first prizes in a row.
Next is the slit lamp photography. Okay, the runner-up, two are there, Dr. Veena Visham and Dr. Brinda K. And the winner is Dr. Veena B.
Dr. Veena B. Please come forward, Dr. Veena B. Oh, that's really nice. Congratulations, madam.
This time we introduced a new competition, that is a Reels competition. And the winner is and the runner-up is Dr. Manju M.
40 plus.
Oh, sorry, winner.
Target. Our families ആർക്കെങ്കിലും ഗ്ലോക്കോമ ഉണ്ടെന്ന് ചെക്ക് ചെയ്യണം. ഡയബറ്റിസ് ഉള്ളവരെ കൂടുതൽ ഫോക്കസ് ചെയ്യണം. കാലങ്ങളായിട്ട് സ്റ്റിറോയിഡ് യൂസ് ചെയ്യുന്നവർ, ഹൈമയോപ്പിയ, ഇവരാരും വെറുതെ വരുന്നു. ഓക്കെ ഗൈസ്? യെസ് സർ. അവരൊന്നും നോക്കണ്ട, നിങ്ങളുടെ ഗ്ലോക്കോമേഷൻ സൈലന്റ് ആയിട്ടാണ് ഈ ഗ്ലോക്കോമ നമ്മളെ അറ്റാക്ക് ചെയ്തത്. ഇവർ നമ്മുടെ കാഴ്ചയെ പൂർണ്ണമായും ഇല്ലാതാക്കി.
സോ പ്രോപ്പറായി ചെക്ക് നടത്തി കൃത്യസമയത്ത് ഡിറ്റക്ട് ചെയ്ത് ട്രീറ്റ് ചെയ്ത് ഗ്ലോക്കോമ നമുക്ക് നിയന്ത്രിക്കാൻ സാധിക്കും.
നിങ്ങളൊരു 40 വയസ്സിന് മുകളിലുള്ള ആളാണെങ്കിൽ ഹാവ് റെഗുലർ ചെക്കപ്പ് ആൻഡ് സ്റ്റേ സേഫ് ഫ്രം ഗ്ലോക്കോമ.
So it is written wrongly as runner-up. Actually, he is a winner. So congratulations,
Dr. Manju, please come up to the stage to collect your prize for the best reels. Dr. Manju, she's coming. Yes, Dr. Manju has come up to the stage. Congratulations, madam. The results will be ready in 2 minutes. I would like to ask someone, I would like to request our sweet judges to have some comments on the OPL. Madam, please.
This OPL was very good. Most of the time, like, you are engaged into seeing those movies, and here we were engaged looking into what exactly next happening. So it was really a very, very entertaining with the science. The science part was really excellent.
Thanks a lot, ma'am. Sir, please.
Yeah, I think it was a wonderful combination of science with fun. But the best part was, as Dr. Namrata madam said, the objective, the audience poll was very objective. I think it is much better than the previous polls that have been held. And it was really reflective of the audience criteria, audience analysis. I think that was a very scientific way of doing it. And there was no bias whatsoever. It was, I think, it reflected the audience mood and opinion very nicely done. Better than the previous OPLs which I have attended.
Better than all OPLs that we have attended, which was, on the voice vote or on hands up. And I would like to really congratulate her. She did a great job with Kahoot and integrating it, getting everybody coordinating. Excellent.
Thank you so much, ma'am. Yes, I was always helped and guided by Dr. Bastin. Even though he appears as a very silent presence in KSOS, he's the strongest in the KSOS, I should say.
3 cheers for Dr. Bastin. Hip hip, hip hip, hip hip.
So a few words, please.
It was a very nice amalgamation of the videos were made so well. The scientific content was good. I thoroughly enjoyed it. It was fun, science, everything together. One of the best OPL.
Thank you so much, sir. Prashant, sir. So few comments.
Yeah, I should really compliment the KSOS for wonderful. In fact, learning for us, we have been a participants in multiple OPLs previously. Most of us have participated, but what we learn is how to use AI so wonderfully. Dr. Sujit, seriously, the way he has fused the science with AI and bringing out such wonderful video was a learning experience to me also. Probably I have participated in 10 or 12, but I came so far to learn. Thank you.
That was so sweet of you, sir. Thank you so much. I hope the results are getting ready. എത്ര ബുദ്ധിമുട്ടായി കാണുമല്ലേ ഇങ്ങനെ ഒന്ന് കാൽക്കുലേറ്റ് ചെയ്തെടുക്കാനായിട്ട്? Yes, madam, please.
No, it's okay. Your name? Yes. So Anjana, since you had asked about the OPL, I would say that as judges, we were sitting there expecting something and we got something else. So what could be better than that? It was science and fun truly together. And this may be a change. I think Dr. Mohan Rajan would agree that this may be a change in the way the OPLs are conducted. So you all are the change makers here.
Thank you. Madam, please.
Yeah, the way they have made the movies, the way they have integrated the AI and all the wonderful apps, the innovative thinking. So hats off to Ksos, hats off to your script writing, and hats off to all the teams. I thoroughly enjoyed and learned a lot myself. Thank you. Thank you, Dr. Bastin, for making me a part of it.
So once again, I thank all our respected dignitaries and all the sweet judges for taking part in the OPL, all the team captains, all non-playing captains, and the team players without whom we are not be sitting here and enjoying this show, right? So I would like all of you to give them a round applause. Once again, please, for their hard work.
dear friends, there's a lot of tight competition between each teams. So we need little more time for judges' marks to come, tablet. So it's a very tight competition. It will be announced during the general body. So because 5:30 we need to start the general body in the Emperor Hall in the Ravis Hotel. So you all come to the general body. There we'll announce the results. Thank you. Sincere thanks to all the judges who took the pain to sit here and evaluate all the videos and all. Thank you, ma'am. Thank you, sir.